Hello, professionals. This is Dr. Saad, and as you know, we are recording series of lecture for pharmacists who are going to appear for international equivalency exam. And today's recording is from the second last section of clinical aspect of endocrine system. So let's begin our topic. And topic of discussion is the menopause. As you know, that menopause is signaled by a woman's last menstruation period and defined as the permanent cessation of menstruation resulting from the last ovarian follicular activity. Menopause have an impact on our ovarian and urogenital system, bone, musculoskeletal system, CVS, and neurological function. So it is mandatory to use an alternative approach that to maintain normal hormonal balance. Otherwise, this all system will be affected by the menopause. So let's see how we will manage it. Hormonal replacement therapy holds a major share in administration or management of menopause in which we use estrogen preparation, and its examples are estradiol with a dose of 2 mg per day orally, or 50 mcg per day transdermally, or 50 mg every 6 months by implant, or 0.6 to 5 mg by conjugated with oral contraceptive or with other therapies. So these are the options of from the side of estrogen as an hormonal replacement therapy. As long as the progesterone is concerned, or also you can also it is known as progestogen therapy. We have option of medroxyprogesterone or dydrogesterone or northestrone or levonorgestrel, and we use them in a combination in a hormonal replacement therapy for menopause. Let's see regime of combination of oral estrogen and progesterone therapy. First of all, first option is to use estrogen for first 28 days and progesterone for 12 days or 14 days, then repeat without interval. This regime will lead for the bleeding after every fourth week. Second option is estrogen usage for 70 days and progesterone use of for 14 days, followed by 7 days placebo tablets, and this regime would lead for bleeding after every 3 months. And third option is the use of estrogen and progesterone continuously. So as long as these combination is being implicated, bleeding wouldn't happen. Fourth option is the use of estrogen continuously, plus you also use Mirans IUS, and there is also an information that bleeding variable, but in this situation we'll use estrogen continuously and Mirans IUS, here bleeding variables. But keep in your mind that levonorgestrel likely to reduce the bleeding and can provoke amenorrhea. So these are the four regimes which is used according to patient situation as an hormonal replacement therapy. Next option we have is the Teblone. Teblone is synthetic steroid and has estrogenic, progestogenic and androgenic effect, and it alleviates menopausal symptom without monthly bleed. So this is Teblone is an also option in hormonal replacement therapy or management of menopause. Next is the selective estrogen receptor modulator, and we have raloxifene as an option for the treatment. One thing keep in your mind that clinical monitoring within 3 months in first instance, that at the interval between 6 to 12 months, so that symptom can be assessed and any side effect of therapy can be reported. So clinical monitoring within the period of 3 months, 6 months and 12 months is required for the assessment and reporting of side effect relevant to therapy. Keep in your mind that we will stop hormonal replacement therapy if we see any of these effects which I am going to mention right now here. If there happen a sudden severe chest pain or sudden breathlessness or cough with blood or stained sputum, or unexplained severe pain in calf or one on the leg, or severe stomach pain, or serious neurological effect, or hepatitis, or jaundice, or liver enlargement, or blood pressure above 160, or you can say systolic blood pressure above 160, or diastolic blood pressure 100 mmHg, or detection of risk factor like prolonged immobility of surgery or leg injury. So if you feel or if you observe any of this effect, then it is recommended to stop hormonal replacement therapy immediate basis. Example of serious neurological effect include unusual severe prolonged headache. This is also one of the effects. So if you see any of this effect, then it is recommended to stop hormonal replacement therapy. There are various other conditions side by side the menopause, which we use to hormonal replacement therapy as a treatment option. So these other conditions are vasomotor symptom, vasomotor symptom, urogenitals, tract, bone, musculoskeletal system, cardiovascular system like coronary heart disease and venous thrombosis, cancer. And examples of cancer are colorectal cancer, ovarian cancer, endometrial breast cancer, and physiological symptom of CNS. These are all clinical conditions in which we can use hormonal replacement therapy as a part of prescription to manage them. Second of the next option for management of menopause is alternative option for hormonal replacement therapy. That includes selective serotonin reuptake inhibitor. It is particularly used for hot flushes, but it is not first line of choice. Secondly, we also have select serotonin norepinephrine reuptake inhibitor uses for hot flushes, but it is not first line of choice. Selective serotonin reuptake inhibitor is recommended for anxiety, and cognitive behavior therapy is used to improve the mood of patient. We also use biphosphonates. Its examples are alendronate, etendronate, risendronate, and it inhibits the bone resorption, increase the bone mineral density, which is a problem in menopause. We also have the option of teriparatide, which is a recombinant form of parathyroid hormone for the management of. After human recombinant parathyroid hormone, we also have the option of aerobic exercise that improves the cardiovascular health and reduces the menopausal symptoms and reduces the body mass index. So these are all clinical management of menopause, and here our topic ends. We are going to open our next topic, that is the rheumatoid arthritis, and why we included it into the endocrine system as a clinical aspect, because as you know, parathyroid hormone play a key role in the balance of body calcium. So calcium is directly linked with the skeletal system. That's why we included this topic in endocrine system. So let's talk about its introduction, and then we'll move on our next clinical aspects. As long as rheumatoid arthritis is concerned, it's a chronic autoimmune condition characterized by the inflammation of synovial joints, and the joints which is involved in it is also known as PIPs, that is abbreviation of proximal intraphalangeal joints, and MCPS, that is also known as metacarpus phalangeal joints. The example of the joints are joints of hand, wrist, knee, ankle, and small joints of feet. Inflammation of these joints are involved in rheumatoid arthritis, and it is not purely disease of joints, and extrapyramidal manifestation may affect the lung, skin, eye, and other organ of our body. So it's a brief introduction of rheumatoid arthritis. Let's talk about its diagnosis. As you know that inflammatory marker like CRP, C-reactive proteins, or erythrocyte sedimentation are non-specific, so we use serology for the detection of RF and ACPAs and anti-CCPs and ANS. As long as the ACP is concerned, it's abbreviation of raised anti-circulatory peptides, and anti-CCPs abbreviation is the abbreviation of anti-circulatory pepprotein antibody, and ANS is the abbreviation of anti-nuclear antibody. So we use serology for the detection of ACPAs, anti-CCPs, and ANS, ANAs, and RF for the confirmation of diagnosis. And other blood parameters like alkaloid phosphate, elevation of platelet count, and raised plasma viscosity, and decreased serum albumin, and increased white blood cell, as well as neutrophil increase, and DAS28 criteria for the DAS28 criteria for the assessment of rheumatoid arthritis. These are the steps for the confirmation of diagnosis of rheumatoid arthritis. So once disease is established, then we will move on. We will use following clinical aspects to manage the situation. First of all, we will talk about the conventional synthetic disease modifying anti-rheumatic drugs. These drugs are actually used to support the progression, and as you know, they have delay onset of action, that is the 4 to 6 week, and before the patient start to see the response up to 4 to 6 months. So its actually onset of action is 4 to 6 week, and 4 to 6 months is required for response to seen. So it's the example which include in DMARDs are hydroxychloroquine. It is used in the dose range of 200 to 400 mg daily, and leflunomide, its dose range is 10 to 20 mg daily. Similarly, methotrexate, its dose is used in the dose range of 7.5 mg to 25 mg once weekly. And subcutaneous sodium aerothionate is used 10 mg as a test dose and 50 mg weekly until significant or total dose of 1000 mg has been given. So we also use sulfasalazine 500 mg, and maximum dose of sulfasalazine can be given till 3 grams per day. So these are the example from conventional synthetic disease modifying anti-rheumatoid drugs. Next option which we use is the glucocorticoid, and it's intra articular, that is known as injection directly into the synovial joints, or intramuscular depot formation, or short-term oral therapy is also used for administration of glucocorticoid. So example is methylprednisolone. It's used as its dose for intramuscular injection is 120 mg, but in a rare instance we can also use 250 mg. It's methylprednisolone dose for oral administration is recommended 30 mg daily. Similarly, prednisolone greater than 5% reduction in bone mineral density is involved. So its safe limit is below 5 with the range within the dose of 5 mg prednisolone for the management of rheumatoid arthritis. So similarly, we also have the option of answer that is known as ibuprofen. As you know, two option answer that is known as ibuprofen and celecoxib. They cause low gastrointestinal complications. Similarly, pyroxicam and ketoprofen has high risk of GIT complications. So ibuprofen and celecoxib is recommended more. So we also have the option of biological disease modifying anti-rheumatoid drugs and tumor necrotic factor inhibitor. There is also a TNF alpha inhibitors. So their examples are adalimumab. As you know that when methotrexate is intolerant in patient, then that patient is being shifted towards the adalimumab, and its dose is 40 mg through subcutaneous route every other week. Similarly, we also have the certolizumab. Its dose is 400 mg, and the pattern of administration would be from first week, second week, and fourth week, followed by the maintenance dose of 200 mg every second week. Similarly, we also have the option of etanercept, and its subcutaneous injection dose is 25 mg twice weekly or 50 mg once weekly. We can also use golimumab, and its dose is 50 mg subcutaneous through subcutaneous injection once monthly. And if patient adequate response isn't achieved, then dose can be shifted towards the 100 mg. And in sometime patient weight, if patient weight is above 100 kg, then its dose can also be shifted from 50 mg subcutaneous injection once monthly to the 100 mg once monthly injection. Similarly, we also have the option of infliximab, and it's 3 mg per kg through intravenous infusion with a period of 2 hours, and it is given for the 2 to 6 weeks after the first, and maintenance dose is for 8 weeks infusion. So it's all about the infliximab and its guideline. Similarly, we need to screen. We should use the screening and safety issues associated with the tumor necrotic factor inhibitor. So discontinue in patient developed worsening congestive heart failure signs. So it was all about the examples of tumor necrotic factors and management of rheumatoid arthritis. So videos, I think, so going too long, and remaining and last section of clinical aspect of endocrine system will be uploaded soon. So thank you so much for listening our video. If you feel that our effort is helpful for you, then please subscribe our channel.